Good evening, everyone. Welcome to Ask Your Mentor session 6 organized by Tamil Nadu AOMSI. Today's topics are temporomandibular joint disorders and cysts and tumors. Mentors for this session are Dr. Darpan Bhargava from temporomandibular joint disorders and Dr. Thangavelu for cysts and tumors. The moderator for the session is Dr. Thomas Sakaria. Dr. Thomas Sakaria obtained his BDS degree from College of Dental Surgery, Manipal, and went on to complete his MDS from A.B. Shetty Dental College. He worked as an assistant professor at Manipal College of Dental Sciences till 2008 before proceeding for a one-year surgical fellowship program at Meenakshi Cleft and Craniofacial Center, Chennai. He has continued since 2009 as a faculty at Meenakshi Ammal Dental College and Hospital, Chennai, where he is presently working as a professor. Apart from publications and presentations and guest lectures to his credit, he has also contributed chapters to Textbook of Oral Medicine and Radiology by Ongole and Praveen, published by Elsevier Science. He has won the Best Delegate Paper Award at the Tamil Nadu State AOMSI Conference held at ECAD February 2018. He holds 2 patents and is currently a principal investigator in a research grant study on temporomandibular disc position changes after orthognathic surgery, funded by Meenakshi Academy of Higher Education and Research. His field of interest include orthognathic surgery, temporomandibular joint surgery, secondary deformity correction, reconstructive surgery, and rhinoplasty. We welcome you, sir. May I now request Dr. Thomas to introduce the mentors and start the program.
Thank you very much. Are you able, am I audible, Dr. Kalpa?
Yes, sir, you're audible.
Thank you very much for introduction. It gives me great pleasure to introduce Dr. Darpan Bhargava, who was doing his post-graduation when I joined Meenakshi Ammal as a fellow in cleft surgery. Dr. Darpan Bhargava completed his bachelor in dental surgery and master's in oral and maxillofacial surgery from Meenakshi Ammal Dental College and Hospital, Chennai. He's a distinction holder and gold medalist from the Tamil Nadu Dr. MGR Medical University for undergraduation and Meenakshi Academy of Higher Education Research, Chennai for post-graduation. He has also successfully completed the Diploma of Membership in Oral and Maxillofacial Surgery from the Royal College of Physicians and Surgeons, Glasgow. He holds postgraduate diploma in Hospital Management and Clinical Research. He is credited with introduction of twin mix nerve blocks for mandibular anesthesia, currently serving as a professor and clinical consultant in the Department of Oral and Maxillofacial Surgery at People's University, Bhopal, Madhya Pradesh. He is the founder director of TMJ Consultancy, Bhopal. He has over 90 national and international scientific publications to his credit. He holds the first ever patent for temporomandibular joint prosthesis. He was awarded a PhD from Meenakshi University, Chennai for his acclaimed research on predictability and feasibility of total alloplastic temporomandibular joint reconstruction using DARSN TM joint prosthesis for the patients in the Indian subcontinent. He's the author for the authoritative book Temporomandibular Joint Disorders, Principles and Current Practice, published by Springer Nature, Singapore. I now call upon Dr. Darpan. We will commence the session on temporomandibular joints. I will be asking, as the moderator, I will be posting the questions to Dr. Darpan, who will be answering the questions that are put forward. Shall we start, Dr. Darpan? Are you ready? Are you ready then?
Yes, Dr. Thomas, thank you. Thanks a lot for the introduction. And in fact, when I was during the final days of my post-graduation, Dr. Thomas was there as staff, and we had had wonderful interaction together in the department those days. And Chennai is kind of a home turf for me, and for that matter, even Tamil Nadu. So I'm privileged to be here. Yes, Dr. Thomas, yes, we can start, please.
Yeah, so the first question in this TMD session is Cabins and anti-Cabins protocol, which is a more valid protocol to be followed? Dr. Darpan, over to you.
Now, when we talk about Cabins protocol and anti-Cabins protocol, let us go to very basics of it first. and then try and gradually get people over calling something anti-cabin for it. From my little experience with maxillofacial surgery and temporomandibular joint ankylosis, I see that Professor Cabin has developed the basic protocol for temporomandibular joint surgeries on which the rest of the current modifications are based actually. So let's understand both the concepts. What is basically Cabin's protocol and how did anti-Cabin evolve? Now, when we talk about protocol on management of temporomandibular joint ankylosis, this is the first most established protocol, widely accepted and maybe widely performed and executed protocol for TMJ ankylosis in most of the countries. Now, let us understand this protocol initially when it was proposed in the year 1990, or maybe when it got published in 1990 in Journal of Oral Maxillofacial Surgery. It involved only 14 patients. He had done this work with a clinical data of 14 patients. In these 14 patients, 18 joints were involved, maybe some were bilaterally ankylosed patients. And then this protocol was based on this clinical data. So that was a very minimal data which we would consider today to develop a protocol on. But the protocol was so robust that eventually it grew with time. So let us just go quickly on this, that it involves aggressive resection. In case the mouth doesn't open adequately, you do a coronarectomy on the same side of ankylosis. If the mouth still does not open to the adequate levels, you again want to do a contralateral coronarectomy, and then you line the gap arthroplasty site with a fascia, usually temporalis fascia, and then you want to in case of pediatric patients, usually you want to reconstruct it with something so that you keep up with the growth in the patient. So what was initially proposed in his protocol in 1990 was costochondral graft, and then rigid fixation of the graft, and early mobilization and aggressive physiotherapy for the patient. So this was his basic protocol when Cabin, Parrott and Fisher proposed it in 1990. Now, eventually in 2009, he modified his protocol and named it Protocol for the Management of Temporomandibular Joint Ankylosis for Children specifically, and incorporated distraction osteogenesis in this. And in case distraction was performed other than costochondral grafting, he said that you do immediate post-operative aggressive physiotherapy, and in case costochondral grafting was used, at least wait for 10 days with the maxillomandibular fixation and then go ahead with aggressive physiotherapy. This is where he modified kind of his protocol for management of TMJ ankylosis in children. Now, when it comes to anti-Gibbons protocol, let us not all of us, as in let us pledge here that we don't call it anti-Gibbons protocol, because he was the one who's laid the foundation to it, and let's not go anti to him. Let us build protocols over his protocol and the accepted norms which are there for temporomandibular joint ankylosis. If such a question comes in even the question papers, let us all as teachers make sure that we do not call it anti-Gibbons protocol, but maybe modifications to the Cabin's protocol henceforth. So that is what I had the reservation in anti-Cabin word per se, because he was the great mentor to develop this basically. Now, let us consider three major issues with TMJ ankylosis. One, when patient reports to you there is the problem with mouth opening. Second, the major physiological problem the patient faces is obstructive sleep apnea because of the microgenia and little space for accommodating the oral structures. And the third one is primarily the secondary deformity which eventually develops with the growth of the child or growth of the person with TMJ ankylosis. The earlier the joint gets ankylosed, the worsen is the deformity with age. And secondly, once the deformity establishes, you need to think in terms of even cosmesis correction. So this reference comes from Professor Andrade's unit from Mumbai, where they say that they found that once they released the joints, they found during the aggressive physiotherapy, patients developed bradycardia. and these were the patients who had severe obstructive sleep apnea. So what they thought was, instead of going by the protocol as proposed, let us change the sequencing of the protocol. So it is not actually anti-Kevin's protocol, it is a modification or improvisation of the protocol according or based on the need. So once the patient's got obstructive sleep apnea in its advanced stages or in its worsened conditions, you want to first correct the physiological problem rather than releasing the joint, which may be a very difficult task as a clinician on the basis to convince the patient, because patient comes to you to open the mouth and you say that I do not want to open your mouth, but I want to do an additional procedure where your breathing will improve and subsequently I will open your mouth. But if you counsel the patient well in advance in a very appropriate manner, this does work. And in cases, what they do is, instead of releasing the ankylosis, they do the distraction first and relieve obstructive sleep apnea, so that patient is physiologically better before the release of the ankylosis. Now the problem with this, why it was thought that the sequencing needs to be given some importance, is when you release ankylosis, specifically for PGs. In case in this diagram you see that this is a patient who needs a gap arthroplasty along with distraction osteogenesis. Again, this diagram is from Professor Cabin's paper. Now you expect that if you have microgenia, the jaw grows forward and down. This is what is expected. But if you have done a gap arthroplasty already and you start distracting, you would have a problem of the segment going back as well. So the gap arthroplasty which you've created may also get covered with the movement of the osteotomy which you've already created. So this was the thought in resequencing it apart from OSA. So now this paper comes from again Journal of Oral Maxillofacial Surgery, where they have staged and done gap arthroplasty first. Subsequently, they have done mandibular distraction and also the correction with genioplasty, and they found that there were equally similar results even in OSA patients if they change the sequence a little bit more. So if you open the mouth and then do distraction, worked well for these guys. And for the previous paper, they said that in case of extremes of obstructive sleep apnea values, which you should evaluate before in microgenia, you need to consider distraction before ankylosis release. This paper again comes from my hometown. My professor and then guide, Professor Ananthanarayan, has worked well on obstructive sleep apnea. And when I was studying, it was his passion to in fact work on this problem in patients with microgenia, and they started doing, maybe this was one of the pioneer papers in pediatric otolaryngology. In fact, it is not the paper in maxillofacial surgical journals. That is why maybe it was less read in maxillofacial areas. But this is the paper which forms the basis that you do distraction first and relieve OSAS, and then secondly release temporomandibular joint ankylosis. So when it comes to Cabin's protocol, please remember gap of 1 to 1.5 centimeters, good 35 millimeter mouth opening. In case you don't achieve it, do a coronarectomy on the ipsilateral side. In case you don't still achieve it, do that on the opposite side. Maybe you want to consider relining the fossa with temporalis fascia, think in terms of reconstruction, early mobilization, and secondary correction. Now, as we discussed, this was the modified one in 2009 for children, again by Cabin, where he incorporates distraction osteogenesis in the management of temporomandibular joint ankylosis. This was the protocol which was developed by Professor Andrade, where they assessed AHI values for OSS, and when they found it to be severe, they wanted to distract first, then release ankylosis before that. And this is again Dr. Parmeshwaran Anand sir and Dr. Elavinil. Fortunately, she's here with us. They've developed a nice flow diagram where you want to just quickly browse through it and decide on what you want to do first and how you want to do it. Dr. Thomas, on to you.
Thank you, Dr. for your explanation. I would just like to add one point, that the original Cabin's protocol was in 1990 was introduced at a time when distraction was not was not a known entity in the field of maxillofacial surgery. If you remember, it was only 1990 that McCarthy published work on distraction. So in the subsequent protocol in 2009, of course, they did introduce distraction, but like Darpan has very elaborately explained, that the so-called modified or anti-Cabin or the modification is that we distract first um, to compensate for the airway issues, and then or rather functional issues are corrected first, and then we address the cosmetic issues of actually ankylosis release and gap arthroplasty. So shall we go on to the next question? So the next question is, what is TMJ Discopexy?
Thank you, Dr. Thomas. Now, when we talk about discopexies, in general, they are a very controversial procedures. No one knows where to do, how to do, which one to do. All that is quite intricate and still a matter of research. But when we generally talk about discopexies, pexy generally means to fix or secure, to fix it in a place and secure it. So this is what pexy means. And when we talk about disc of TMJ in particular, it becomes discopexy in cases of TMDs, and otherwise disc is also known as meniscus. So it is also referred to as meniscopexies in reference to temporomandibular joint derangement procedures problems. Now, when we talk about temporomandibular joint as such, you understand that temporomandibular joint has got an articular disc, which is kind of a padding between the two bony surfaces, and the disc wants to move along with the translation of the mandibular condyle and wants to cap the condylar head all the time so that it protects the bony surfaces. This is what should normally happen. But when this synchrony is altered or disturbed, you may have a problem like this, which is seen in this picture, where you see that when the patient is, or this person or the lady is trying to open the mouth, you have the disc which is already anteriorly displaced. Although you may have different type of disc displacements now, which is well documented. You may have anteromedial, pure anterior, lateral, posterior, medial, and so forth and so on, in a combination of all of these. So to simplify, if the disc is displaced, like in this case it looks anteromedial or anteriorly displaced in a 2D diagram, and when patient is trying to open the mouth, the disc pops back or slides back onto the condylar head to achieve its normal position, or the position it should have. Now this is the condition of disc displacement with reduction. Now when usually patient has this problem and there is a mild click and patient does not bother, it usually doesn't affect anyone, either the patient or the clinician. But when these problems become symptomatic, then the entire spectrum of problems start for the patient, and you tend to start thinking what can be done. Another scenario would be when you have a disc which is displaced and which is hindering the movement of the condyle, like you see in this picture, where the disc is displaced but does not reduce back. So this is disc displacement without reduction. Now again, when this problem, usually these patients initially will come up with reduced mouth opening, eventually they will have adequate mouth opening, but they may get symptomatic at times. So when they get symptomatic, there is a procedure which is documented in literature, which is called as discopexy or meniscopexy. Generally what you do is, when you have a displaced disc, you want to remove some amount of tissue, as you see at a place number 3 in the diagram A. That is the retrodiscal tissue which has come anteriorly, and the disc is displaced much anterior to the condylar head, almost lying at the level of the eminence, which is number 2 in diagram A. Now what is performed or executed is, you remove the portion of a retrodiscal tissue as labeled number 4 in figure B. You remove the portion of this tissue, so you in essence shorten the retrodiscal area where you see this number 4, and you tie it off there. This can be done as an open procedure, where you reposition the disc back onto the condylar surface. So this can be an open surgery, or you can attempt doing this, reposition the disc using an arthroscope. Now arthroscopic procedures are growing, and more people are getting trained into this art and science. So this is also a possibility, although it requires specialized skills, training, and also your proficiency in level 3 arthroscopic procedures. So what you do is, you pass a thread or a suture at the discal region, junction in the retrodiscal and the disc, and you try and pull it back and tie it to a position so that the disc does not displace back in its anteromedial or anteriorly displaced position. So you secure the disc at a position so that it caps the condylar head. Now, other procedures which are documented for this particular hinging of the disc or repositioning the disc is now talked about is mitic pin fixations or anchors. The mitic anchors, what you do is you remove a portion of retrodiscal area and you reposition the disc and you hinge it or tie it to a small anchor at the distal area of the condylar head so that the disc does not get displaced anteriorly and it is held on by the mitic anchor in the posterior position as you do it during the surgical procedure. So this again can is ideally done as an open surgical procedure for the joint. Now, Dr. Professor Thomas is also there with me, and I know he had worked very hard for this project. Where what they do is we do not in India actually we do not get these mitic anchors that easily. The feasibility is less, and the cost factor involves too much. So what they did was, although this was for the meniscocondylar dislocations, but this procedure is done for even repositioning the disc. What you do is you take a orthodontic mini screw, which is just like an anchor, and you insert it in the posterior aspect of the condylar head, and then you reposition, then you pull it back. This may be the one possibility which can be thought of to reposition the disc. Other than that, you have open discopexy procedures, where you again shorten the length of the retrodiscal area and tie it in different way as proposed by Moore, then Dolwick, and then a lot of other authors gave their own techniques. But basically you shorten the retrodiscal area and tie it. Other hinging procedures which are documented for discopexy is that you hinge the disc to the condylar head through sutures or wires. This can be done using K-wire. You make a hole in the condylar head. Now you have got good rotary instruments, so that can be utilized to get this hole, and then fix the disc on hinge it to the condylar head directly. Or other than that, documented procedures also involve hinging the disc to the even temporal bone. So these are the few procedures which should be kept in mind before we think in terms of discopexy or meniscopexy procedures. It can be done as an open procedure, open surgical procedure, and secondly, it can be done as an arthroscopic procedure. Over to you, Dr. Thomas.
Yeah, thank you, Dr. Darpan. Like as Dr. Darpan has elaborated, discopexy is nothing but just anchoring the disc to the to condyle. Basically, it addresses all issues of internal derangement where there is there is a conflict between the condyle and the disc. All conditions of internal derangement, there is a discrepancy or a conflict between the condyle and the disc. I mean, he's already explained all that. So what you have to do is just make sure that the condyle and the disc move in unison. And for that to move in unison, you anchor the disc to the condyle. And Dr. Darpan has highlighted the various techniques you can anchor the disc to the condyle, either using a mitic mini anchor or an orthodontic mini screw, or directly with just a hole on the condylar head. So that is basically what discopexy is, just attaching the disc to the condyle so that the disc and condyle move in unison, and it addresses all these issues of internal derangements. So the next question is, which is the best autogenous graft for reconstruction of TMJ and why?
On autogenous graft, let me start with saying that all the grafts which are there and are being executed are all being tried, and nothing is materialized as the ideal graft for TMJ as yet. But yes, when we talk about grafts, these few grafts should be kept in mind, that the autogenous grafts which are usually used are costochondral, sternoclavicular, fibular, coronoid itself, the elongated coronoid which you cut, you can fix it at the condylar region to form the artificial condyle, and now people are using metatarsopharyngeal areas to graft temporomandibular joint. Now, what was proposed initially by Cabin was costochondral graft, which was widely practiced. Now, the problem with this that it was expected to grow along with the growth of the child. Now, as the costochondral graft has some growth potential or documented growth potential, now it did not keep pace because it is a graft from a different site implanted at different area. It did not keep pace with the growth of the child. It either overgrew or undergrew or failed. So people do not trust this as much and do not endorse it as the graft. But yeah, it is a good material. It has got cartilage as well as the bony component, which can be easily fixed onto the lateral ramal area. And it does at least provide vertical maintenance of the vertical dimension of the ramus of the mandible till the child grows off and you want to perform a secondary corrective procedure on the child. So it does has good hold currently in terms of validity. Now when we talk about the grafts in general, surgeons generally prefer costochondral graft because it had been widely practiced, and most of us are trained in this art and science to harvest it and to implant it, so we are more comfortable with it. But with growing science, even distraction is taking good space apart from costochondral grafting. And moreover, now with coming tissue engineering science which is growing, you have areas of developing vertical bone and cartilage for reimplanting at the TMJ size. That's still a field of research, but yes. So if we go by literature in particular, now again I would quote IGMS 2012. It says that to date there is no ideal autogenous graft for condylar reconstruction that satisfy the complex anatomy and the myriad of functions of a missing condyle. But still, if you want to go to most ideal, it would be costochondral at this instance. Apart from costochondral grafting, you have a growing science of TJRs, or total joint replacement systems, which are coming up in the market. Most of us are trying to attempt and practice them. Now, on that, this would be a wonderful reference from Dr. Sidebottom, which is published in Journal for Journal for Biology and Craniofacial Research in 2013. Now he divides the entire reconstruction with alloplast or autogenous material into two aspects of it: one, childhood and adult. In childhood, it says autogenous grafting and distraction osteogenesis and local osteotomies are a preferred option. And you may want to do alloplastic reconstruction when these grow into their adolescent ages, in case the autogenous graft fails or does not perform as expected. Now, in adults, the directions are majorly in favor of alloplastic reconstruction per se. They say that alloplastic performs well, although we do not have too long-term data. The last paper I read was 20 years data on alloplastic functioning and performance. So in adults, alloplastic reconstruction to maintain the vertical height is finding its way, and in children, local osteotomies, distraction osteogenesis, and alloplastic reconstructions are should be preferred as the primary option. Now, when we go into other aspects of it, you see that a lot of material have been tried and tested, a lot of have been obsolete and are rejected now. Then again, there's a reference from Dr. Anant Narayan and Dr. Ilavinil's book on head and neck reconstruction, where you can see pros on. In this, you see that all the three pluses with the prevalence of recurrence and restoration, vertical height, and then growth will go with costochondral grafting. So I would say that because we all of us are well trained in it, and it performs a reasonably okay job for pediatric patients, I think that should be considered as the option for total, as in the replacement or reconstruction of the vertical ramus and the condylar portions. So with that, over to Dr. Thomas again.
Thank you, Dr. Darpan. The next question is something that would be of interest to non-surgeons also, for the non-surgical management of temporomandibular joint surgery or TMD disorders. The question is, what is the role of hard or soft splints for a TMJ internal derangement?
Now, when we talk about the splint therapy for TMDs, actually we are missing on a lot of randomized control trials and meta-analysis on this aspect, and we have limited data on endorsing any particular splint therapy for any particular condition as if now, if we go by literature. apart from the individual personal experiences of the clinicians. Now, these splint therapies are otherwise referred to as occlusal appliance therapy for TMDs, and the physiological basis which these splints work on is that they decrease loading on the temporomandibular joint, and they reduce neuromuscular reflex activity, and that's how they try and work. When we attempt and use a splint for bruxism or MPD cases, we see that they work by changing the vertical dimension and altering the proprioception and in the postural positions of the mandible. So this is the mechanism of action. Now at the postgraduate level, apart from other many splints which are available, we should generally know about these two splints in particular: the stabilization of flat plane splints and the anterior repositioning splints when it comes to TMDs. Now when we talk about stabilization splints, it is a full coverage splint which balances the bilateral occlusion. Now how it works, it relaxes the muscle, it aids in joint stability in general, and protects the teeth from bruxism. And what it does is that it gives the even contact bilaterally and simultaneously disoccluding the original occlusion. Now when it comes to anteriorly displaced disc, now let me tell you that the stabilization splints are generally indicated for extra articular uh, myalgia problems. In particular, when you have muscular related pain, this splint usually works well. But you have another splint which is called as anteriorly repositioned splint, which has got a plane where it positions your mandible a little anterior than its normal position. Now this particular type of splint is indicated when you have arthralgia which is of intra-articular origin because of condyle disc fossa relation conflicts. Now when you have internal derangement problems, this is the splint which has to be advised, and which can be subsequently replaced with maybe the flat plane splint at a later date. When it comes to soft splint, it is usually made of a soft polymer, and usual indications for a soft splint is for bruxism and post surgical intervention, where you want to disocclude the maxilla and the mandible in the post operative phase, or you want to advise a splint after you have intervened within the joint with a minimally invasive, maybe arthroscopic procedure or arthrocentesis. So this is the splint which is indicated in such a scenario. Now in general, when we talk about splint, this is the reference from our own manual which we have compiled. In general, you need to think in terms of theories which are proposed by Glenn T. Clark. It enumerates as restoration of vertical dimension theory, TMJ repositioning theory, occlusal derangement theory, cognitive awareness theory, and maxillomandibular ailment theory. Now we need to understand all these things, and then when we go about splints from occasion, you have n number, Dawson, you have n number, and a lot of splints in each classification. So in case you want to go into more details of this, take down this reference and go ahead with that. But in general, at least you should know about stabilization splints and the anterior repositioning splints. Now when it comes to softer and harder material, this reference was aided to me by Professor Thomas again, that the hardest splints deforms less when a patient tries to bite or keep the teeth in contact, whereas the softer material would maybe compressed a little more than the harder material. So with the harder material, you would have more of a kind of isometric kind of contraction, and whereas in a softer material you would have a isotonic kind of a contraction. But at places, at references, a combination of splint therapies have been applied, the flat plane and the repositioning splints and the flat plane splints, and they supposed to work in combination also well. But again, we are missing on randomized control trials and a lot of meta-analysis on this topic, and we need to work more harder on a specific type of conditions and also where to indicate what. But in general, intra articular problems, anterior repositioning splints, and myalgic problems, the flat plane splint should be preferred. So I will skip few of the slides because considering we have limitation of time. But again, all these slides endorse what we already spoke about the splints and the occlusal therapy on in TMDs. Over to Dr. Thomas again.
Thank you, Dr. Darpan. Uh, I would just like to make one point here. One of the good studies that have been, which Dr. Darpan showed, was the study by L. Morrissey. This is a meta-analysis of the efficacy of splints, occlusion therapy and splint therapy in TMDs. Al Morrissey has done a lot of work in collaboration with Wolford, Ellis. Please read some of his, and he is specialized in meta-analysis and systematic reviews. He's got a few articles on TMJ. He's done a lot of meta-analysis in arthrocentesis also, whether open joint surgery is better compared to arthroscopic surgery. So he has done a lot of work, and his systematic reviews are really worth reading. This is one of those. So for the postgraduates, please follow this particular author. Thank you so much, Dr. Darpan. And I'll go to the next question. Can an impacted wisdom tooth be a cause for internal derangement? Does occlusal rehabilitation have a role in treatment?
Okay, now again, why the controversy? That initially we were occlusal centric and trying to treat most of the TMDs with correction at the occlusal levels, and then eventually we started treating TMDs as a separate entity. Now let me clarify on this, that occlusion and changes in occlusion with age, with orthodontics, or with maybe eruption of third molars may bring about changes in the occlusal table. Now, usually your temporomandibular joint is meant to remodel or keep modulating as and when required according to the need, the forces, the occlusal table, and the entire stomatognathic system in general. So it keeps remodeling. It's got a lot of cartilage and it keeps modifying itself as per the need and the loading it gets. So this is what is the controversy. See, once you have the initiation of the problem and you can intervene or intercept, get onto occlusion. But when you get a established temporomandibular joint disorder, try and treat the disorder per se. Don't go back and start blaming the occlusion because this was bad and this has happened to you, and now I want to correct this because you have had this and your joint has gone bad. But once your joint has gone bad, it has gone bad, you start treating it as a joint. So now it has shifted from occlusion centric management to more of the joint centric management systems. But yes, interventions at right time is a good thing to do. Now when we talk in terms of third molar, this is one reference where I found it is, although in the journal for orthodontics, where they say that there were occlusal changes and it eventually had the influence of occlusion with third molars and eventually going on and affecting the temporomandibular joint. So third molar eruption does have influence on occlusal changes, and that secondarily may have that eventually may have changes in the temporomandibular joint. Now joint tries to remodel. Now only at times when joint loses its pace of remodeling along with the changes within the joint to the changes happening at the occlusal level, may it be during orthodontics, the eruption of third molars, or any other reason, loss of teeth, loss of vertical height, or any other reason for that matter. So when the joint remodeling loses pace, it is happening at a slower rate, your occlusal changes are happening faster than the joint can remodel, you will have established TMD which develops. Now, when it comes to third molars, especially we all of us must have observed that when you start getting buccally erupted third molars, it starts abutting with the medial aspect of the ramus, and patient tries to do some kind of lateral excursive movements to adjust the mandible to close the mouth in a comfortable position, because the third molar is hitting on to the medial aspect of the ramus of the mandible. So this is one case. Even when your third molar in the lower arch starts erupting, you would see that there would be pressure changes and you would have minor occlusal changes. And again, temporomandibular joint would want to keep pace and get remodeled according to these changes. When this pace or this disturbance occurs and you have loss of pace with remodeling, you have problems of TMDs which get established over a period of time. Now, does occlusion have a role? Now, there is a lot of talk about disclusion time reduction therapy. It is purely based on occlusal rehabilitation. So, in case you want to go in a little details on this, please go ahead and read about TEC scan, the T scan, which is there, and the disclusion time reduction therapy, which is usually a non-invasive therapy of minute changes in the biting forces by maybe removing some amount of tooth structure in ameloplasties, and by adding some amount of tooth colored material at certain places where it is required, maybe composite buildups, and then it is combined with T scan and EMG scanning so that you have balanced forces on both the sides. So again, when you have established TMD, again highlighting on that, when you have a problem which is established, don't go ahead and start doing all this. First, you manage the joint, make the patient asymptomatic, and maybe then you come back and try and see what was the problem initially. Over to you, Dr. Thomas, please, on this.
Thank you, Dr. Darpan. The next question is arthroscopic findings during progressive stages of osteoarthritis.
Okay, once we talk about arthroscopy, I would be going a little fast because we are short of time on this. So, but when we talk about arthroscopy, see, first thing what we should know is a good anatomy of the arthroscopic joint through arthroscope within the joint, because it looks quite different when we see it in actuality or while open joint surgeries. Now, this reference again given by McCain, provided to me by Professor Thomas. They've graded different kind of joint derangements from grade 1 to grade 4, where grade 1 is a milder form and grade 4 is the most severe form. We'll directly jump onto the changes which are seen. Now, when we enter with the arthroscope, you see the synovium which covers the joint, and you see these engorged vessels. These are usually the signs of synovitis. When you see these engorged arteries or the vessels within the joint in the synovium, this is the initial change of synovitis, followed by erythema and synovitis, which is a more progressive stage of initial synovitis. And then I've put this picture of severe erythema, where you can compare it with a normal joint on your left side and the erythematous joint on the right side. So this is even more extremer stage of maybe erythema and synovitis. And then you would see that you will have got a lot of fibrillations which form the adhesions of the fibers which form and join different areas in different parts of the dynamic areas of the temporomandibular joint. So you would have fibrillations which eventually form, and then you have a entity called as pannus, a growth from the synovium. You see a pannus which is developed there in a deranged joint. And then just to compare, on your to your left you would see a normal kind of a joint, and on your right you would see a joint which is into advanced stages of osteoarthritis. So these are the changes. So you start with synovitis, with engorged vessels, you go ahead with erythema, you go ahead with pannus formation, fibrillation formation, and at times you would also see disc perforations, which the documented picture I do not have right now. Over to Dr. Thomas on the next question.
Thank you, Dr. Darpan. Now, it's an interesting question for you. You have to play very carefully here. Does estrogen play a role in TMJ dysfunction?
When I take this question, I would say yes, it does. Now, I should not get the beating, so I would say with limited evidence, because Dr. Thomas initially told me be very careful about it.
You have to be very diplomatic when you answer this question.
I intentionally wrote yes with limited evidence. So I was diplomatic when I made the presentation itself. But when I was reading through it, it was very interesting. And when we were compiling a book, we did a lot of work on estrogen, and so we found that if you go by literature, even the high levels of estrogen were associated with TMDs, and low levels of estrogen were associated with TMDs. Now, this is a systematic review of literature where you see they are talking about both the low levels and the high levels eventually affecting the joint. Now, what exactly happens is that you have got estrogen receptors which are present in the intraarticular cartilage, and with the modulation in the levels of the estrogen, patients have ups and downs in their symptoms, which is documented. Again, the level of evidence is low because it needs actually more research. Now, when we go on to this reference, again, this reference in particular is provided to me by Dr. Thomas, where they say that even cyclic changes in the estrogens have its effect on the TMJ derangement uh, disorders in particular. Now, this particular diagram clearly tells you that you do have receptors for estrogen in the fibrocartilage which is present within the joint. So at this stage, we would say that during the cyclic changes in the estrogen, it does affect the joint with ups and downs of symptoms. But what it exactly does and how it does has to be still studied further.
Thank you, Dr. Darpan. Very tactfully and very carefully tackled the question. I like Dr. Darpan has correctly pointed out. We don't have definitive answers yet, and it's a field of ongoing research, and we just have to wait for further evidence to come out whether before we can definitively say a yes or no to this particular question. This is the last question for this the TMJ session. Which is the most common and what are some of the most common and practical modalities to treat repeated subluxation of TMJ?
Okay, before I move on to this question, just in particular about the last question, why we are trying to study that is that in most of the text we find that there is relatively higher prevalence of TMDs in female patients than the male counterparts. So that's where we are trying to see what is different in the joint and why it is affected more in females. Now, moving on to this question in particular, common modalities for subluxation. Now, let us understand the problem with subluxation is that the joint translates. Now, A is the normal anatomy, and B is where the joint has translated further ahead of the eminence. Now, how further ahead is again the matter of study, that how further ahead you should label the patient as subluxation. But I see that if the patient comes to you with a symptom and you have something like this, it is subluxation. Now, what exactly happens is this. Now, when the joint moves further ahead or translates further ahead during the course of the movement, you have the stretching of the retrodiscal area. And we have such a stretch of retrodiscal area. This retrodiscal area is the culprit which causes all the pain and the symptoms to the patient. So, when you have such a problem, this is what is happening in the patient. Now, when we go on to the management of it, you talk about minimally invasive techniques where you do botulinum toxin. What you do is you toxin the musculature which causes these movements. Usually, EMG guide, the most established now is EMG guided lateral pterygoid botoxin injections, and the second option is autologous blood injections, which would cause some amount of local fibrosis in and around the joint. It can be injected intra-articular. There are documented cases of peri-articular injections, so within the joint and around the joint, again with the risk of maybe developing ankylosis if we go by literature. But this has been tried and kind of worked for some of the patients. And the third option is prolotherapy using different materials, maybe dextrose or sclerosing agents. So this is what can be done as a minimally invasive measure on a daycare basis. Other than that, surgical interventions includes immunectomy, which is kind of, if we go by literature, is a documented and established procedure for subluxation, that you remove the hindrance at all. Other procedures include blocking or sling procedures and surgery of the capsule ligament. So basically, when you want to answer this question, you divide it into three components. One is anchoring procedures. You do a procedure where you tighten up the ligaments of the joint, maybe the lateral tightening or the antero-posterior tightening, but you do some kind of an anchoring procedure or the ligamentous procedure where you tighten off all the ligaments by a procedure. Because I remember one of the senior professors talking about that what he used to do is just give a nick at the capsule and leave it. Once the capsule heals, there would be some amount of fibrosis and patient would be relieved of symptoms in subluxation. So any of these procedures. Then you have blocking procedures where you want to put a graft or down fracture the arch in front of the condyle so that it cannot come forward or translate to anterior. People have even tried mini plate fixations at the eminence so that it does not come anterior, putting some block grafts so that it does not come. Established Daughtry's procedure is there for subluxation. The second picture is more of a Daughtry procedure with a plate, but usually Daughtry in essence did not describe a plate fixation. It just described down fracture of the arch. Or then the third procedure would be elimination of all the hindrances. So you do a eminectomy, you remove the eminence, and so the condyle moves freely forth and back, and you have no symptom. So these are the, in short, the basics of this procedure. In case you want to read a little further, I would suggest you read the book by Professor Daniel Laskin, who's unfortunately no more with us and it's quite a loss for oral surgery actually. But TMDs by Laskin is the book to read. And in short, in case at the postgraduate level you want to read, we've compiled a small manual for you, just 200 to 300 pages manual, a book which can give you some insights into the TMDs. Now, again, these slides, courtesy Dr. Thomas, he's given me this classification where we can divide it into anchoring procedures, myotomy procedures, and blocking procedures, and procedures to eliminate blocking factors. So just keep this in mind and maybe place one of the procedures in this and try and attempt for your patient. But when we go by literature in general, I would say that again, Dr. Thomas's procedure of mini screw fixation also does work for subluxation, where you make the disc and the condylar head as one unit. The entire thing moves as one unit and patient becomes asymptomatic. You go off with the retrodiscal area completely or totally. Now, when we go about all this and we do read about the meta-analysis, some of the reviews, it is, if you want to go for an open procedure, eminectomy is one procedure which in general finds vote by most of the authors, and other procedures follow the line. Over to Dr. Thomas on this.
Well, thank you, Dr. Darpan. I would just like to add one point in there's a lot of classification of dislocation that has been elaborated very nicely by Dr. Darpan. Finally, a lot of surgeons do, there's a consent, they do go for eminectomies. They just remove the any obstruction in the path of the closure. That is what the eminectomy does. Basically, any interferences in the path of the closure, they remove that. And that is one of the commonest procedures used. But a recent article by Dimitrilis in 2018, they also propose disc repositioning along with eminectomy. This is the slide you're seeing, the last slide that Dr. Darpan is sharing. This article published by Dimitrilis and co-workers, which came out in BJOMS about 4 years ago. They do for recurrent dislocation, they do propose disc reposition, because according to the authors, it actually counteracts when you reposition the disc backwards. Since the lateral pterygoid is inserted into the disc, it kind of counteracts the pull of the lateral pterygoid and prevents this recurrent dislocation of the joint, in where the lateral pterygoid is usually implicated in recurrent dislocation. So more research has to be done, more series of cases have to be done, whether eminectomy plus disc reposition is a robust and a long-term procedure for recurrent dislocation. So thank you so much, Dr. Darpan, for this wonderful session on temporomandibular joint. I hope the postgraduates and all maxillofacial surgeons who have joined in did learn something. It's not possible to cover the entire spectrum of TMJ in half an hour, but we've had the wonderful experience and expertise by Dr. Darpan, we have tried our best to cover as much as possible. So thank you so much, Dr. Darpan.
Thank you, Dr. Thomas, for a wonderful pleasure. In fact, I see a lot of questions in the chat box, but we do not have time. So in case someone is interested, they can ping me on email, which is easily available online, and we would address most of the questions there, or direct it to the organizers, and eventually we would answer most of them. Thank you very much.
you, Dr. Darpan. Shall we move on to the next session?
Yes, sir.
Which will be on cysts and tumors. And our next mentor definitely needs no introduction. He's very well known in our fraternity of maxillofacial surgeons. He's a regular at all conferences and all webinars. You would all be familiar with Professor Dr. Thangavelu. He's currently the professor in oral and maxillofacial surgery at Annamalai University. He's a diplomat, National Board of OMFS, fellow of Indian Board of OMFS, and he's presently the chairman of the Indian Board of Oral and Maxillofacial Surgeons, or IBOMS, Central Council member of ITA, immediate past secretary of IBOMS, past joint secretary and president of AMSI Tamil Nadu Pondicherry chapter, past editor of ITA Tamil Nadu State Journal, the assistant, associate, and sectional editors and editorial board member of the our association journal of maxillofacial and oral surgery. He's got 100 plus international publications, 400 plus guest lectures and presentations, orations. He was awarded Best Teacher Award 2011 by Annamalai University, and Best Award in 2014 by IDA Tamil Nadu State Branch, Best Academician 2019 IDA. So over to you, Dr. Thangavelu, who is an authority on pathology, and very aptly we have chosen him as a mentor to teach our postgraduates and young surgeons on cysts and tumors. Thank you so much.
Thank you, Thomas. Hope my slide share is visible.
Yes, it's visible, sir. Thank you, sir.
Okay. So thank you for the kind introduction. Good evening, everybody who are here. We had a fantastic temporomandibular joint session. None other than Darpan, who is a hot man today all over the nation, who talks more about temporomandibular joint, who does a lot of work, and he also educates on temporomandibular joint. Very good. It was a nice session being there along with him. And my job here to fill up this Ask Your Mentor session is on cysts and tumors. And those old days when we used to go to conferences, we used to run behind mentors to have a breakfast session with them. Now the advances of technology brings all the mentors to you at home, and you're learning, all students and young budding surgeons are learning things from the mentors and experienced people. I wish the AMSI Tamil Nadu chapter and I congratulate for constant effort of office bearers and under the leadership of Johnson for giving us such a fantastic webinars and clinical discussions on various topics. With these few words, I would like to request Thomas to put down the questions for me.
So the first question that has been asked is what is the difference between peripheral osteotomy versus marginal resection?
Okay, before going into the details of the question, the topic of discussion today is only about the cysts and tumors of maxilla and mandible of the jaws. So this particular condition is very, very straightforward. And most of the conditions are handled in a dental office-based procedure. And only very rarely we take larger lesions to general anesthesia and do a reconstructive work. And most of the cystic lesions are managed in the dental office procedures. And it's very straightforward, and there need not be any skeptical discussions on the various available, well-established treatment of cysts and tumors of the jaws. Especially the question put forward today by one of the listeners is about peripheral osteotomy and the marginal resection. When we talk about the resection of a tumor or any pathology in a mandible or in a maxilla, it is it depends on the clinical extent of the lesion, how the cortical bones are involved, how far the alveolar bone and the basal bone is involved, how extensively the tumor is involving the mandible and maxilla. Then the radiological extent, clinically something is evident when you take a radiology, there can be a radiological extension of tumor, and confirmedly the nature and the pathological issues related to the tumor is more important on doing a treatment for benign tumors, especially benign tumors. So another important factor which comes to point is about the age of the diseased patient and the comorbidities associated with the diseased patient. So with these ideas, the main thing what we conceptually look upon when we treat a benign tumor is whether to resect the mandible totally, that part of the mandible which is affected by the tumor, or you give some consideration and leave back the continuity of the mandible. So basically it is two types. One is with continuity defect and the second one is without continuity defect. So without continuity defect is removing that involved part of the mandible maxilla without disturbing the basal bone, and give some continuity to the remaining part of the basal bone. So in that, two types of things is there. One is when you remove and block the tumor, that you call it as an en bloc resection. And in cases like KCOT or odontogenic keratosis or any other tumors, ameloblastomas, where there is a lot of invasion into the surrounding cortical bone, if the lingual cortical bone is involved, and you want to resect an intraoral upper border tumor, and you are removing along with the soft tissue and along with the lingual cortex involved, or some marginal bone is also removed, that is called as a marginal resection. And that is also can be called as a rim resection when you take only the alveolar part of the bone, while leaving back the basal bone or leaving back the basal skeleton. And regarding this peripheral osteotomy, one of the very common cystic condition, cystic tumor condition, or OKC, what we come across very commonly. The only problem with this OKC is rate of recurrence. And we all understand the pathology, the pathological aspect of OKC as the daughter cyst or the satellite cyst, or the reasons for one of the reasons for the recurrences. So it is not only the main tumorous part should be removed, it is also the extended micro invasion of the tumor or a cyst which is going into the surrounding bone also should be taken care of, apart from the majority part of what is removed. And that is what is called as your peripheral osteotomy. So after removing and block the tumor mass, you go little behind according to the radiological informations and according to the histopathological informations to go remove all the daughter cysts or remove all the micro invasions into the surrounding bone. And this is only thing difference between a peripheral osteotomy and the marginal resection. So marginal resection is one part of the tumor, either upper part of the tumor is removed along with one cortex or both the cortex and soft tissue without having any disturbance in the continuity of the mandible. A segmental resection is what remove of a segment of bone. It can be hemimandible, it can be only the body of the mandible, it can be the angle and the ramus, vertical ramus of the mandible with the continuity defect. And peripheral osteotomy is after en bloc resection, you go extensively into the surrounding bony structures to remove all the micro invasions. And that peripheral osteotomy can be done using a sort of burr or a cutting instrument. This is what a marginal mandibular defect or a marginal marginal resection, what I call what I was explaining earlier. And this can also be called as a rim resection, and this is an anterior segmental mandibular resection. This is an hemimandibular defect, an hemimandibular resection. And when you remove a cystic cavity or a tumorous content and you want to go into the surroundings of hard tissues, and you want to drill up and cut all the surrounding soft tissues with an extension with your round burr, and that is called as a peripheral osteotomy. Hope I was clear in my explanation between a marginal the procedure and the peripheral osteotomy procedure. So the problem of this peripheral osteotomy procedure is we are not very particularly measured amount of bone. We can't like just something like removing with the rongers and removing with the cutting instrument. So when you remove with the burr and you do a peripheral osteotomy, we can't actually measure whether we have completely removed it or not. So we need to give a very understandable margin when you do depending on the histopathology. And only thing is when you do an extensive procedure after enucleation or after end block resection, you might have a problem of damaging the adjacent tooth structure, because we need to conserve as much as tooth possible without involving the tooth structure. So doing a peripheral osteotomy can disturb the root apex of others, which needs an endodontic treatment and things like that, which can involve the neurovascular bundle and the mandibular canal also. So especially when you do a chemical cauterization, which is another form of a peripheral procedure. So I hope I'm very clear, especially this peripheral osteotomy is done in odontogenic keratosis in order to avoid and reduce the pattern of recurrence, as it is literature says that odontogenic keratosis is one of the commonest recurring cystic lesions of the jaw. Thomas?
Can you, yes, sir. Can you go to the next slide, sir? Yes.
So that is about the cystic lesion. And if you want to have more ideas about resection on the mandible, this is an interesting article which gives the role of the tumor invasion into the bone. And that is the evidence for us to do what type of surgical procedure. If it is a solid ameloblastoma, or it is unicystic ameloblastoma, or any other variety of ameloblastomas, histopathological variety like follicular, flexiform ameloblastomas. There are a standard tumor invasion into the bone, where the unicystic ameloblastoma usually has got 0.25 to 5 for 0.5 centimeters, where follicular goes a little bigger and the granular goes still deeper. And accordingly, you need to give the surgical margins and then go about with the resection of the tumors. So radiological margin 1 to 1.5 centimeters are considered safe and accepted by many of the surgeons, and even evidence-based. And there are a lot of tumor extension radiographical margin in ameloblastomas has been reported, which varies from 2 millimeters to 8 millimeters. And an average of 4.5 millimeters. So as radiological evidence, 1 to 1.5 centimeters of safe margin will be more than enough for us to do the surgical resection. So after resection, this will be the defect. What we have, the defects are classified like this, and depending on the segmental resection of the mandibular in ameloblastomas with good margins. Yes, Thomas. Hope I'm clear with my answer.
Yes, thank you so much for your very elaborate explanation, sir. I just have one question for you. Regarding a peripheral ostectomy, how do you, in your personal experience, arbitrarily remove the bone? How do you do the ostectomy? How do you, since it is a very inaccurate technique of removing, do you have any technique of clearing the margins arbitrarily?
I just use the same old technique of putting a big round bar and then rubbing entire margins all over. That is the standard technique. What do I follow?
Okay, sir. Okay, sir. Thank you so much. The next question is recent advances in the management of ameloblastoma.
Okay. Coming to ameloblastoma per se, there are a lot of confusions which was existing in the middle of the earlier in olden concept. It was only a resection and immediate reconstruction if possible, or they put a immediate plate to maintain the continuity of the mandible. That was a standard technique, what all we learned and what all we did earlier. But after the advances of virtual surgical planning and your patient-specific implants and your medical approach on such type of aggressive tumors, All this has changed the concept of management of ameloblastoma, especially when it comes to the age part of it, and when it comes to the extent of the part of extent nature of the ameloblastoma. So there are roles which has been depicted in literature about the molecular level involvement in ameloblastoma and how they can approach it at the molecular level, so that there is a little cure and there is a promising medical cure for ameloblastoma, because it is not an easy affair just to resect the mandible and then do think of reconstruction, and none of the reconstruction will be very apt for a huge resection of the mandible, because we all know, even if you put a double barrel or a free fibula flap, it will not be adequate enough for us to do a dental rehabilitation. So before resection of a mandible or a maxilla, especially maxilla, it's very difficult to reconstruct. So the recent advances are conceptually thinking about and concentrating more on the molecular level, and they are towards the conservative method of treatment, rather radical method of treatment, though we promisingly practice this radical resection of mandible ameloblastoma in all these years. So there are a lot of drugs, which is, I don't have any personal experience in this, but when I go to literature search, there was a lot of mechanism which was explained, and there are a lot of mutation and genetical role which was explained, and the importance of target therapy was emphasized in most of the recent articles. But it is not evidence-based, it is still in a research, and there are a lot of medications which can be used, which inhibits the mutation of certain genetical mutants, and that reduces the growth factor, and it reduces the ameloblastoma, and it cures the ameloblastoma. So these are some of the drugs which is medically used recently in ameloblastomas, and there are certain disadvantages associated with this drugs also, like cyclopamine, which is used. It's got a disadvantage in the proper healing of the tissues also, because they have an indirect effect over the skin. But this article gives a very interesting concepts on current aspects of ameloblastoma, management of ameloblastomas, and things like that. Oh, hello.
I can hear you, sir.
So in nutshell, in recent advances in management of ameloblastomas, benign lesions, especially if it is a conventionally excisable or resectable lesion, we can do a resection and an appropriate reconstruction, which is a time-tested and a standard method of treatment. And recent innovations about medical management and drenching procedures can also be considered in a cystic lesion or in a cystic type of tumor, and where you do repeated enucleation so that there is a healing takes place, and the reduction of tumor size comes down. And afterwards, you can also do a staged procedure of doing a minimal resection. And the third one is the virtual surgical planning and going in for a patient-specific implants to fix the plates, to fix the bone grafting, whatever bone graft you use. All that also are the recent advancements in the management of benign tumors and ameloblastomas. Over to you, Tom.
Thank you, sir, for that wonderful explanation on the current concepts in the management of ameloblastoma. You've covered both medical and surgical aspects of it. The next question is on sodium tetradecyl sulfate injection, sclerosing agent. So what is the dose and duration protocol for sodium tetradecyl sulfate injection for hemangioma?
Actually, the management of hemangioma is it needs a special care, and you need to be a little trained in managing. Not all of us can just handle an IV malformation or a vascular lesion per se. We all know that it bleeds a lot, and in olden days, our teachers used to teach about, and even classical textbook explains about the quilting, putting circumlesional sutures to minimize the blood, all those things, and then you also embolization, which can be done, or the recent attempts to reduce the amount of bleeding intraoperatively. So even I used to discuss some of my cases with Sanjeev, who is a pioneer in southern India, about this AV malformations and vascular anomalies. And there are a lot of sclerosing agent which is intentionally injected into the lesion to get the entire lesion fibrosed or sclerosed. So these are the important agents. You have sodium morbate, which is standard, sodium tetradisulfate, and bleomycin is also one of the very commonly used. And Sanjay has told me I've used 2-3 cases with the promising results where the entire lesion has come down, a little amount of fibrosis and sclerosis has taken place. So the question was not about what is the role of these sclerosing agents, but they've asked about the technique of using it and the dosage of using it. Especially if it is you all know that the vascular lesions are classified as high flow and low flow lesions, and the surface lesions as hemangiomas and hematomas. So what is the dosage which is described in the textbook is 0.1 to 0.5 ml of 3% sodium tetrasulfate is intraoral hemangiomas at an interval of 2 to 4 weeks. This can be even extended little for a bigger lesion, and the dosage can also be increased slightly if the lesion is little bigger. So this is a standard dosage, and the 3% STDs solution contains 30 ml of STS and 0.2 ml of benzyl alcohol, and 9 milligrams of dibasic sodium phosphate and anhydrous water with injection of which will be with a pH of 7.9. So this particular combination of intralesional injection with sodium tetradisulfate is more recommended, and these are the 2 evidences which we could give you on such type of intralesional injections. As Darpan was also explaining, we can also give such type of injections inside the temporomandibular joint to shrink the joint space, and then to reduce the mobility of the condyle, reduce the mobility inside the joint. Similarly, here in hemangiomas and vascular malformations, especially the concept and idea is to minimize the bleeding during the procedure, surgical excision. And when you want to do that, we can stage it by giving a injection of sclerosing agent, which sclerose the entire tumor mass and which helps the surgeon to give a very good clearance. Only thing is, the surgeon always goes totally away from the lesion and never invade into the lesion when you are handling any type of AV malformations or vascular lesions. Hope I answered the question, Thomas.
Yes, definitely, sir. It was a very elaborate explanation. Now, the next question is there a role of cryotherapy in the management of benign cysts?
Okay, cryotherapy, lasers, electrotherapy, all this is an adjuvant armamentarium in our maxillofacial surgery. There is no, we can't particularly say that this particular cryotherapy has got a very good role in certain aspect. And in those days, we also did a cryo-freezed mandible as a lyophilized mandible as a source of bone grafting. So the cryotherapy, yes, all of us understand the methodology, how this cryotherapy works. It is by a Joule-Thomson's principle. And when a compressed air of nitrous oxide is expressed through a simple orifice or a small orifice, there it gets freezes. So once if you keep this cryo probe, it is just like an electroprobe. It has got a ball-ended, it has got a flat-ended and things like that. Conventional cryo guns can be used to place the tip of the probe onto the lesion, especially mucosal surface lesions. Surface mucosal lesions like mucosales in the lower lip, in the upper lip, and some small petechiae and small vascular lesions in the cheek, or small vascular lesions in the lip can also be used with treated with cryotherapy. And especially when you want to go in for an intra-bony lesion, the cryotherapy comes in a way only when you want to do some sort of cryo-freezing or cryo treating the surrounding bone on a OKC2 in order to reduce the recurrences. So when you want to do an en bloc resection and you want to make a safe margin, even after that you want to just treat the surrounding bone, doubting and bony infiltration or bony evasion, then you can use a cryotherapy in OKC for after doing an enucleation surrounding bone, something like a peripheral osteotomy. The advantage of these cryosurgeries are you need to go in by a freeze-thaw cycle, what we call it as freeze-thaw cycle. In a mucosal, if you place a cryo probe, it gets freezed. After some time, you can see only an ice just on top of the mucosal, and you allow that to wear off. And when it thaws, then you can do another cycle of cryotherapy. So it is done in multiple cycles, freeze-thaw cycle, and especially it is documented as an adjuvant therapy in OKC and with a lower recurrent rate of 20%. And this is the quoted article for the evidence of this use of cryotherapy in a low recurrence rate of OKCs. Apart from this, using a cryotherapy in any other intra-bony lesions as a primary treatment modality has not been evident in any of the literature and not been used by most of us also. So cryotherapy is an adjuvant armamentarium, and it can be used in surface lesions like mucosal and small cystic lesions and mucous retention cysts. And it can also be used as an adjuvant procedure to take care of the surrounding bones in ontogenic keratocyst. So hope I have answered it, and especially these are some of the references of which has given some evidences about nitrous oxide cryotherapy in management of benign lesions in oral cavity and especially in ontogenic keratocyst. Thomas?
Yes, sir. Can you go to the next question, sir? If you change the slide.
Yes. You can go to the next question.
The next question is, this is an interesting question since there's a lot of talk on 5-fluorouracil being used instead of carbonated solution. So, Dr. Thangavelu, can you answer this question? Can 5-fluorouracil be used instead of carbonated solution? What is your take on this?
Yes, we don't have clinical experience on that. We have just started a dissertation on this topic. But on treating, maybe I would have treated about some 60, 70 OKCs. I have a series of ontogenic keratocysts which was operated. And most of the cases, we use a sort of carbonized solution, which is a standard method of chemical cauterization, either a conventional carbonized solution or a modified carbonized solution with some alterations in the content of the coronae. And the modified carbonized solution has had advances over the conventional carbonized solution, because the invasion into the micro invasion or the invasion of these carbonized solution and the chemical used in it into the surrounding bone is about 1 to 1.5 depending on the area of the bone we apply. And when you keep the carbonized solution in after the enucleation of the cyst or after the removing of the pathology, there will be a slow invasion of this carbonized solution, chemically cauterizing the surrounding bone and necrosing the bone. When in the vicinity, if there is a neurovascular bundle, the neurovascular bundle is also damaged. So in order to reduce the amount of infiltration of this carbonized solution, they used a modified carbonized solution. And that was very predominantly used nowadays as a modified carbonized solution. And that has got a less invasion to the neurovascular bundle, less problematic to the surrounding soft tissue because of the minimal invasion. The third one, which has come in recent time and which is taken a big way in recent literature, is 5-fluorouracil, which is which they consider as a novel therapy in treatment of ontogenic keratocyst. And again, the treatment is based on the targeted to the lower recurrence rate and less morbidity, as I told, with the modified carbonized solution. And there are a lot of explanations how this 5-uracil works. And they also given a scientific evidence that the particular identification says that this 5-uracil is very, very efficient in an inflamed OKC. Suggested that increased the article suggests that an increased 5-uracil efficiency in an inflamed odontogenic keratosis. So when you want to handle inflamed cyst where they have attempted some surgeries earlier or before, and if there is some amount of inflammation, the 5-fluorouracil works out better. And the technique can be used for the areas of cortical perforations, in contrast to the relative contraindications of your modified cornice in areas of cortical perforation, especially when there is all of us know when a cyst expands, it erodes, it expands and it keeps eroding the outer cortex. At the outer cortex is thinned down, it becomes eggshell crackling, then it becomes a perforation in the outer cortex goes in, to the soft tissue. So at that time, using such type of cornice solution or an aggressive solution may be problematic, where we can still use this 5-fluorouracil as one of the adjuvant targeted therapy for odontogenic keratosis. The article which is suffixed here is one of the evidences in 2017 in Journal of Oral Maxillofacial Surgery about the use of 5-fluorouracil and the cornice solution, modified cornice solution. See, there are two types of 5-fluorouracil. The 5-fluorouracil is a common anti-metabolite which is used for basal cell carcinomas and most of the surface skin lesions. Cosmetology is used as a 5% cream. 5% cream of 5-fluorouracil is used in getting the dark marks on the face as one of the topical applications of basal carcinomas and things like that. So the same 5% cream can also be used as an agent to keep in the odontogenic keratosis after enucleation. Especially in modified cornice solution, we take the solution into in a gauze. We just squeeze the gauze and then keep that into the surgical site for 2 to 3 minutes. That is the standard protocol what we follow for cornice solution or a modified cornice solution. But since 5-fluorouracil takes its own time to evade into the surroundings of tissue and it is a little slow, what we need to do is we take a rubber gas, we immerse it into this 5% 5-fluorouracil and pack the entire cavity after enucleation. Do a primary closure, only let a small gauze which is letting outside so that we can remove it after 24 hours of pack. So it needs to be there for a certain time of 24 hours for it to act effectively. Hope I answered the question, Thomas.
Definitely, sir. Thank you so much for your explanation. Shall we go to the next question, sir? If you could change the slide. Yes, sir. This is an important question which would be especially beneficial for the postgraduates. This is a question on what is the recent classification of ameloblastoma?
Okay. Ameloblastoma has been taught and it has been understood in various forms from earlier timing. In my old days and even today, some of my senior professors will accept that one of the principles called as Kramer's hypothesis. It was an hypothesis put forward by Kramer. He said ameloblastoma travels only in the medullary space and more on the medullary space when compared to the cortical bones. And that is why we see most of the ameloblastoma in a linear fashion than in a buccolingual fashion. You take any number of ameloblastomas, you will only have a linear spread of ameloblastoma. There will be initially there will be minimal expansion of cortical bones. That is one of the criteria of Kramer's hypothesis, which is put forward earlier in ameloblastoma. There are also a lot of something like our Shannai's classification in TMJ. There was a classification, radiological classification by Lavunda is in about ameloblastoma. All this is time tested, and we've been practicing on based on these type of classification, which was put forward by Laskin and so many people earlier. But recently, when we go into action and want to do a surgery, for an ameloblastoma, we need a clear picture what are the types of ameloblastomas. And in recent article in 2017, WHO has come out with a very, very new classification with a flow chart, which clearly and which easily explains the ameloblastic classification. They have only classified ameloblastoma into 3 main categories. One is the conventional variety. Other one is the peripheric variety, which is totally on the soft tissue part of it. And the third one is the unicystic variety, which is a unique variety of ameloblastoma, which is of concern nowadays. And there are, because of the histopathological variations and the outcome, the surgical outcome and things like that. So ameloblastoma recently by WHO 2017 has classified into conventional, periphery, and peripheral ameloblastoma and unicystic ameloblastoma. In conventional ameloblastoma, they have categorized only 2, and they have responded other type of histopathological ameloblastomas into other category, and they have only categorized, one is a flexiform type of ameloblastoma, and other one is a follicular type of ameloblastoma, which is most common type of ameloblastomas, the conventional variety. So in unicystic variety, depending on the evasion of the tumor into the lumen and into the intralumen and transluminal, they are classified as mural ameloblastoma, luminal ameloblastoma, and intraluminal unicystic ameloblastoma. So, even the desmoplastic ameloblastoma was reclassified as a histological subtype and not as a clinical pathological entity, though there are certain evidential characteristic features are lying with desmoplastic ameloblastoma. And this is another important article what I would like to suggest for the postgraduates in 2019, which has given the current aspects of a new classification by WHO. And all that solid, multicystic, multitrabecular pattern, all that is discarded, and it should not be confused with any type of unicystic ameloblastoma. So basically, we have two types. One is a conventional ameloblastoma and a unicystic ameloblastoma, which is central or inside the bone, and the third one is the peripheral ameloblastoma. In conventional ameloblastomas, we have 2 types. One is flexiform, and the other one is the unicystic ameloblastoma. We have according to the evasion into the lumina. So these are the latest classifications of ameloblastomas. Especially in the unicystic ameloblastomas, these classification help us to plan the treatment appropriately. If the involvement of the luminal epithelium, the cystic epithelium, or whether it is are evading into the surrounding bone, all this gives a clear idea whether to go in for a conservative management or a radical management. So that is the standard proposal from WHO 2017, and we do follow these type of classification without confusing much with other histopathological classifications and radiological classifications.
Thank you, sir. Thank you, sir. Yes, thank you for shedding light on the classifications of ameloblastoma and the intricacies associated with it. The second last question is, what is the recent evidence in the non-surgical management of giant cell lesions of the jaws?
Another interesting part of benign tumors is our giant cell tumors, because we know in exam point of view, most of us get trapped with this giant cell tumors, and aneurysmal bone cyst, management of aneurysmal bone cyst, and other giant cell issues. We all understand that the multinucleated giant cell presence histopathologically is very important in this giant cell, and there is a lot of medical treatment which is put forward for this giant cell, apart from the surgical treatment. Central giant cell tumors and central giant cell lesions should be managed aggressively. There's no doubt about it. And in the medical management, there are a lot of interesting materials which has been used, which is one is salmonal calcitonin, which is causes bone formation and calcification by antagonizing the parathyroid hormone. By treating it usually longer than 12 to 36 months, which is absolutely necessary. So if you identify, there is also certain formulas available in treatment of giant cell lesions, which is put forward by Howell et al. I will come to that when it comes to steroid therapy. So calcitonin is one of the, salmonal calcitonin is one of the drugs which is used as a treatment for giant cell lesion. Interferon is one of the drugs which is an anti-angiogenic drug which is injected subcutaneously after curettage. It is an adjuvant therapy for after curettage of surgical management. We also give an interferon therapy. So the treatment option, as a treatment option, an aggressive central giant cell lesions. And there are certain newly invented drugs, newly upcoming drugs like denosumab, which is a human monoclonal antibiotic. Even these type of drugs have come in a big understanding during our COVID situations. So this drug is again inhibits the receptor activities of the nuclear factors in rankle, and that also treats the giant cell lesion. So when you adapt such type of intralesional injections or an adjuvant drug, that reduces the tumor mass, and it avoids an aggressive surgical excision or surgical resection in a giant cell tumor. So steroid is again one of the, as I told you, Howell has introduced one of the formulas, and steroid is one of the injections which can be given intralesionally when you have an osteolytic lesion, especially giant cell granulomas, 1:1 solution, and triamcinolone is used for that at 20 milligrams along with epinephrine, and it can be used in an higher concentration of drugs for greater intervals between injections. When you use a little more of these drugs, you need to take little gap using this, and continuous injection through 3 shots, 4 shots of the injection may reduce the tumor mass and may reduce the lesion, which helps us, the surgeon, to go ahead with the resection. Or there are evidences, there are literature, very minimal literatures available on these drugs which has completely cured and repaired the bone in the site of this giant cell tumors. So this is one of the articles which supports the use of calcitonin and intralesional steroids, which is come out in 2020. And apart from that, the surgical management is as good for any other tumor. You give a good margin and do a resection with or without reconstruction. Thomas, hope I have answered the question.
So can I just add one point here? See, giant cells are basically tumors with central giant cell tumors are basically they seem to have the tumors of giant cells. So basically, the steroid inhibit the osteoclast formation. They inhibit osteoclast formation because giant cell tumors are nothing but a proliferation of osteoclast. So that is, and also steroids have an anti-inflammatory, immunosuppressor, anti-transcription action also on the inflammatory cells. And also they inhibit the extracellular production of lysosomal proteases, which mediate osteoclastic bone resorption. So these are some of the mechanisms of action that steroids have on the intralesional therapy for giant cell lesions. Just wanted to make that point. Shall we go to the next question?
Yes, for the postgraduates and students who are attending examination, especially there will be a tricky question on this giant cell tumors, and you need to know about the medical management, because one area of benign aggressive lesions where medical treatment is concentrated in recent years is this giant cell tumors. Thank you, Thomas.
So the next question, can you, and the last question is there a difference in the treatment strategy or reconstruction protocol in the management of benign pathologies between children and adults? It's a very interesting question. Dr. Tandavedu, can you please?
Yes, of course. Of course, when we talk about reconstruction after resection, Yes, the main problem is the pathology, handling a pathology with the pediatric age group and with the adult age group and the even geriatric age group. There are subtle differences between managing such type of benign tumors on the 3 different ages. The concept of understanding should be very clear whether we are going to do an immediate reconstruction or a delayed reconstruction. That again depends on what type of lesion we are handling, whether it is a very aggressive lesion, for example, very aggressive lesion, or very non-aggressive or a simple method, benign tumor. So the first one thing what we should understand is whether we are going to take up for an immediate reconstruction. Sorry for the spelling mistake there, and delayed reconstruction. The second one is how far and how fast we are going to dentally rehabilitate these patients. Because ultimately, when you talk about reconstruction, it is to maintain the form and function of the mandible and maxilla. Not only that, we should also give importance as a basic dentist to the dental structures. So giving a good form to the mandible is not only enough without putting a good denture on top of it, or without putting an implant-based denture or implant-based dental rehabilitation on top of it. So the strategy should go when you come across such any type of benign tumors, whether the benign tumor is aggressive or less aggressive, whether you're going to do a conservative or a radical, or whether you are going to take up for immediate reconstruction or a delayed reconstruction. There are certain aggressive tumors where because of various reasons, we may delay the reconstructive procedure. We will take some time later to do a reconstruction and there is no recurrence of the tumor. Is also possible. But most of the lesions are immediately reconstruction with, if it is a benign lesion, immediately reconstructed with a free fibula or a free microvascular flap, which favors us for a early dental rehabilitation. Even nowadays, they have come out with various other implants like bicortical implants, where they can, lengthier implants can even reach the basal reconstructed bone. And there are other methodology which is available where we can plan a resection by means of virtual surgical planning. Our CTARS is doing a great job in this. Most of our resections because of our mucormycosis and recession because of extensive tumors are done virtually, virtual surgical planning about how to give the margins, and we customly do a patient-specific implant without, even in conditions where we can't do a reconstruction properly with adequate bone grafting, we can go in for a patient. That is all for a general treatment, but general surgical management of let me show some of the clinical pictures, because I was very urging to put all the clinical pictures earlier, but I could not collect all the pictures. So I have few clinical pictures. This is one of the OKCs, which was initially diagnosed by an incision biopsy. And we did a surgical resection, leaving back the lower border. We did a sort of marginal resection for this patient. And the histopathology turned out to be a squamous cell carcinoma arising from the epithelium, cystic epithelium. So there are possibilities of tumor changing into a malignant variety also. So in those cases, we need to be very cautious enough, and we need to be very skeptical in getting the histopathological picture of the tumor before trying to operate. And this is the case where we have later waited for 1.5 years for then resected the entire mandible and then reconstructed with a sort of bibarrel free fibula flap. So according to the evidences and according to the evidences of invasion of this ameloblastomas, especially unicystic ameloblastomas, the management can be of various types. It can be, if it is only limited to the epithelial, the cystic epithelium, then you can go ahead with the cystic enucleation. And if there is an invasion of the ameloblastoma into the lumina and not outside the cystic layer epithelium, then it is called as intraluminal extension, and that can also be managed by means of an enucleation procedure. Whereas if there is a micro invasion of the ameloblastoma outside the epithelium and it is transmurally, if it comes out out and it goes near the surrounding bone, then you need to do a little aggressive enucleation with peripheral osteotomy or peripheral chemical cauterization or whatever it is. And then third one, if it invades into the surrounding bone, then the only choice for you to do aggressive resection with adequate margin and then to do immediate sort of reconstruction. So this is the immediate reconstruction, what we have done with free fibula, and the patient is 10 years off the track with the bicortical implants onto it. The only problem with this free fibula flaps is we'll be able to reconstruct only the lower border of the mandible and we'll not be having an adequate alveolar portion. And that is the reason why we do a double barrel also. Even then, we will not be having adequate alveolar bone, and putting a dental implant on the alveolar reconstructed bone will be very difficult. So that is the reason why today with the bicortical screws and longer implants, which takes this purchase and stability from the basal bone, the dental rehabilitation is also come up a big way in such type of immediately reconstruction mandible. This is again one of the cases of adult where we can do a surgical planning, virtual surgical planning, and you can have a guides, fantastic guides. Our CTARS John Nason does for us, and most of I'm addicted to such type of guides nowadays. Without guides, I don't do much of TMJs and such type of patient-specific implants. And these guides can be adapted along the tumor mass. You need not check about your margins. You can, there is a small groove through which you can make a cut, and the entire mandible part can be resected, and the custom made or a patient specific implant can be fixed by using a similar guide for putting the drill holes of the plates, and then you can put the patient-specific implant with a sort of implant extension to the intraoral area, where in cases where the patient is associated with comorbid condition, patient is not willing for a microvascular, free microvascular grafting or any type of bone grafting, such type of patient-specific implant has come up a big challenge, and it has been done quite across the globe with good results in severe excision of the in resection of the mandible and reconstruction. This is what the patient specific. It gives the good stability and contour of the mandible, and it gives not like a conventional AO plate where it stays somewhere. It is planned well because it's planned by a virtual planning, and the patient specific implant also helps us to early rehabilitate with the dental with the implants. So this is again algorithm which is put forward in a pediatric for pediatric tumors. As I told you, for adult tumors, the management is different. In pediatric tumors, the management is different because we are handling a mandible which is growing, a maxilla which is growing. And they have come with an algorithm saying that the biopsy should be taken, and if it is a unicystic ameloblastoma, enucleation is a choice. And according to the Ackermann's type, you start treating. And if it is a conventional ameloblastoma, resection and reconstruction should be opted. So what is that, the invasion we are talking about? This is the different invasion of unicystic ameloblastoma. So this is the epithelium, and if there is an invasion into the, only with the epithelium, we call it as you can do an enucleation. And if it is going into the surrounding soft tissue structures and connective tissues, then a more aggressive type of treatment should be done in unicystic ameloblastoma. The controversies and the confusion of managing lies only with this unicystic ameloblastoma and cystic ameloblastoma, whether to do a conventional therapy or to go in for a resection and reconstruction. There are other tumors also which should be taken into consideration, especially OKC, as I told, peripheral osteotomy is a must. Ontogenic myxomas, where the resection can be done with an adequate 1 centimeter margin, is very more than adequate, especially in the mandible and in the maxilla. And central giant cell lesions, as I told you, we can also use medical treatment in management apart from non-aggressive lesions, for non-aggressive lesions. And for non-aggressive lesions, a simple curettage can also be performed in central. For aggressive lesions, where you can expect or reported rate of recurrence 30% going for aggressive treatment. So there are even after curettage of gentle cell lesions, after enucleation, there are evidences with the high rate of recurrence. So interferons, corticosteroids, calcitonians can also be added as a medical treatment or as adjuvant therapy in treatment of central giant cell. Taban also put forward as published promising results in combination of curettage of aggressive giant cell tumors with the adjuvant interferon therapies, which is a golden standard for aggressive lesions. But whenever there is an aggressive lesion, there is histopathologically proved aggressiveness and radiologically extension, you should go in for a en bloc resection or aggressive resection of the tumor. This is one of the pediatric, it's not a benign ontogenic tumor, it is one form of juvenile ossifying fibroma, it's a fibroosseous lesion. And one interesting thing which we have observed in this case is we did intraoral resection of the mass tumor or a fibroosseous lesion because of considering 8 years of age. This was about 12 years back, we operated this patient and we did an immediate reconstruction plate. After 10 years, we could see a total bone reforming here. I don't know how this happens in a benign lesion or ontogenic tumors, but in a growth, whenever you maintain the periosteum, which is not invaded by the pathology, if the periosteum is clean and neat, there can be bone formation from the cambial layer of the periosteum, which is the inner layer of the periosteum, and that can lead to the auto bone regenerate. So this is other observation which I made and which I wanted to bring it to your notice. For a growing child, that you can also take a chance of doing a resection without primary reconstruction, because we can work out whether some amount of bone formation or auto bone regenerate which takes place. You can see here about 18 years old girl, now she is undergoing a implant procedure with bicortical screws. It is ready and we are going to deliver to her tomorrow or day after. And this is the amount of bone which is formed by itself by the periosteal suturing, not any type of bone grafting done for such type of patient. This is one of the interesting factors when it comes to pediatric age group. And when it comes to geriatric age group, where we can't plan for an autogenous bone graft, another technique of a transport disc, but I had very minimal experience with transport disc, especially when it is a lateral defect. You can still try doing a transport disc or a distraction osteogenesis, where you travel a small disc of bone from one side to opposite side and allow the bone to regenerate in between, which is a standard. And Meenakshi has done an extensive work on transport disc, and Neelakant and Sarah have also done an extensive work of transport disc distraction. And but when it comes to the anterior region or a anterior segmental dissection, which is very difficult for us to think about any form of good reconstructive material apart from your microvascular, which should be curving, what you call it as a curving. You can do a unicortical cut and you have a template for it. That is also virtually we can plan it and we can do a reconstruction. So coming to the end of the discussion, children need to be specially taken care. It can be immediate reconstruction with microvascular can be avoided if you expect some amount of bone graft formation. Or else for aggressive tumors, we need to resect and reconstruct it with the free vascularized bone graft. And these are some of the evidences for pediatric maxillomandibular reconstruction and geriatric maxillomandibular reconstruction. Thomas, hope I have cleared with my explanations.
Thank you, sir. I would just like to make one point here that the diagrams you show about the unicystic amyloblastoma's various involvement of the lumen and the capsule, they are taken from the Oral and Maxillofacial Pathology by Robert Marks and Diane Stern. It's a very good book for pathology. In my opinion, that's probably the only book in pathology written by a maxillofacial surgeon. I urge all postgraduates to read about cysts and tumors and a lot of other benign and malignant pathology from this book, Marks and Stern. And the algorithm that Sir gave on the Ackermann the resection and the treatment algorithm based on the Ackermann classification, that's same as the diagrams that are shown here. Basically, in Ackermann class 1 and 2, there is only the involvement of the epithelial lining, whereas in class 3, there is infiltration into the capsule. So that's basically those diagrams that are shown here about the cystic ameloblastoma, whether the tumor is restricted to the lining or whether it invades the capsule. And of course, the treatment protocol is what Sir already explained very eloquently. And with that, I think we've been very fortunate.
One more. Apart from this conventional method of resection, conventional method of en bloc resection, additional treatment option for a well encapsulated tumor is an access osteotomy. Especially when you get a complex type of odontoma or a big, huge lesion in the angle of the mandible, we can go in with the unilateral sagittal split osteotomy and then remove the entire tumor mass from inside. And I've also done few cases like that with and there is also good literature evidences about supporting this access osteotomy when you want to remove an well encapsulated radiopaque mass from the radiopaque tumors from the mandibular angle and especially mandibular angle. And Brosh procedure is one of these procedure which was explained earlier for OKC and various other procedures. Also, you can remove the outer cortical plate by doing a osteotomy and then remove the mass and then put back the cortical plates. Only thing is, don't not much jeopardize the blood supply as much as possible. Some periosteal attachment should be well engaged with the cortical bone so that you can open it like a book, remove the tumor mass without going into extensive surgical resection. So access osteotomy also should be taken into consideration as one of the treatment options for a well encapsulated benign tumors in the angle of the mandible. Thank you, Thomas.
Thank you very much, sir. We've all been very fortunate to have Dr. Thangavelu talk on pathology, cysts and tumors. With his more than 30 years of experience, surgical experience in this field, I think we've all benefited by his immense knowledge on all kinds of tumors and cysts, and definitely all sorts of pathologies, and not only the postgraduates but also all maxillofacial surgeons. You're always a student in maxillofacial surgery. I feel there's nothing like a young surgeon or an experienced surgeon. You're always a student. So and listening to Dr. Thangavelu always sparks that enthusiasm to keep learning and reading and researching about newer aspects and techniques in our field. So with that, we conclude the session on pathology, cysts and tumors. I hope the postgraduates and everybody who logged in found this beneficial from both our mentors, Dr. Darpan on the TMJ and Dr. Thangavelu on cysts and tumors. Thank you very much.
Thank you, sir. With this, we come to the end of the session. On behalf of Tamil Nadu AOMSI, we would like to extend our heartfelt gratitude to the mentors and moderators for their valuable contribution and sharing the knowledge.